is the correct image. What many of you have confirmed also. That is, I think the question also said progressive quadriplegia with the following image. And that is the basilar invagination. Now, this is a very straightforward question, which all of you have already told. Now, moving on to the next, that is regarding the blood. Okay, hypernasality of voice. Okay, so next question, that is the blood-brain barrier is present in which of the following structures? So all three of them are the circumventricular organs, that is the area prostrema, neurohypophysis, and the correct answer here is the anterior pituitary. Okay, the blood-brain barrier is present in anterior pituitary, not present in this three. Okay, so the correct answer for this question is anterior pituitary. Moving on, which is not a prognostic factor in RCC. So I have searched in Bailey, in Campbell. I've searched in Campbell, Bailey, and what I found is the best answer is age is not a prognostic factor in RCC. Tumor size, nuclear grade, and pathological grade are all prognostic factors for RCC. Okay. So if you see, this is from the Campbell, this two references, and this is from the Bailey, and they have mentioned regarding the histological type, they have mentioned regarding the pathological stage. Okay, age is not a prognostic factor for RCC. That would be the correct answer. Moving on to next, that is a dynamic sentinel lymph node biopsy. So in this is the reference from the NCCN guidelines and even from Campbell, which is told that it is basically done for the non-palpable inguinal lymph node. So the clinically impalpable nodes inguinal is the indication for doing a dynamic sentinel lymph node biopsy. Okay, so that is a correct answer here. Now, testicular tumor, which of the following statements is true? So according to the Bailey as well, the mean half-life of AFP is 5 to 7 days. So this is incorrect. This is incorrect. Now, if we talk about the testicular tumors, HCG of 5,000 does not have poor prognosis. It is more than 50,000. Okay. So that is according to the IGCCC. Yeah. Okay. So these three are incorrect. So this is the correct option and this is the correct answer. Okay. According to the Campbell, mostly all the Euro questions, I felt that they have been framed from Campbell. I could not find any reference from the Bailey, Savastin, or Schwartz. So regarding distal hypospadiasis, which procedure allows for orthoplasty, that is basically chordae correction and urethroplasty to be performed at the same time. And this is again direct, that is TIP technique is used more than 90% of the time for distal hypospadiasis repair. So I hope this question is correct and the options are also fine. Yeah. So for this question, the answer is tubularized incised plate. Now, which of the following is not done on back table during pancreas transplantation? So please help me out with the options. Are these options correct? Yeah. So we do arterial reconstruction, we do splenectomy, we also oversee the stump and also the mesentery. So this is again from Schwartz. So removal of spleen, shortening, restapling, suture reinforcement of the mesentery, trimming of duodenum, arterial reconstruction, venous reconstruction is not done on back table in pancreas transplantation. So that is the correct answer in this question. Okay. Oversewing or shortening. Okay. So even if you see from Savastin as well, so basically we do the arterial reconstruction because we need to take a Y graft to do the connection between the SMA and the splenic artery. And other than that, vascular reconstruction does not involve venous reconstruction. Okay. Next, post-renal transplant, urine output was, so duodenum shortening, basically extra duodenum, bowel, everything is shortened to match so that you have the graft ready with adequate ends so that you can put it in the patient. So venous reconstruction is never done. So that will be the answer for that. For renal transplant, urine output was observed after removal of arterial clamps and after shifting to the ward, patient develops anuria, bladder irrigation is not helpful. Now, it was renal arterial thrombosis. It was renal vein thrombosis, catheter block and rejection. So usually in immediate postoperative period. So now, according to the Savastin, which has given in detail regarding the complications, that is within 2 hours. So usually, as per the Savastin, renal vein thrombosis will present with either hematuria or decrease in urine output. Acute rejection will not present in such a way within 2 hours. And catheter blockage already has been ruled out. I think bladder irrigation was there in the option. So the best answer would be a renal arterial thrombosis. If the thrombosis was in the option, then it is the correct answer here. Okay, next, that is regarding alkalosis for every 0.1 increase in pH. I hope this options and question is correct. I'm confirming each question so that there is no discrepancy later on. So please, if it's possible, please be quick in that. So yeah, this is again a straightforward question from shorts. They've taken a lot of questions from shorts as I'd expected last year as well. So it is decrease of potassium by 0.3 for every 0.1 increase in pH. And for the kidney transplant, the best answer is renal arterial thrombosis. And for the pancreas transplant, the best answer is venous reconstruction. So moving on to the next question, that is which is not a dam. Now this is again a straightforward question from the Schwartz. And the best answer is apoptotic bodies, IL-1 alpha, heat shock proteins, and mitochondrial DNA are all the options given. Yeah, so as I said, transplant for pancreas, venous reconstruction, kidney, renal arterial thrombosis, 2 are the answers. Okay. And in this, the answer is apoptotic bodies is the answer for this, which is not DAMP, that is damage associated molecular pattern. Okay. See, if same options are there, then apoptotic bodies is the answer according to the DAMP. Now coming to next, that is patient is on warfarin and clopidogrel. What should be given to prepare the patient before surgery? Now, usually you need to reverse the effect of warfarin. So here the PCC has been given. I think this is also exact options what was there. So the option with PCC is correct because for warfarin, you need to give PCC for reversal of the effect. So I hope the options and the question is correct in this. So moving on to next, that is which of the following statements about VEGF is true. So now this is also again from Schwartz, wherein it stimulates the endothelial proliferation and increases the vascular permeability. What was the fourth option? If you guys can help me out with that. Okay, but yeah, according to the Schwartz and according to the okay, so it simulates endothelial proliferation and increases vascular permeability. That is again taken from the Schwartz, and that is the answer for VEGF is if the question was what is true. Next, for free flap surgery, patient presents with venous congestion, dark bleeding, exploration, thrombosis noted at anastomotic site. What is the next best step? So is the answer, is the options and the question correct? Or is there any modification in this? Okay, so if exploration was in question or mostly any, yeah. So if exploration is already done in the question, the best answer is reanastomosis for any free flap surgery. If you have any kind of worry about the venous or the arterial congestion or thrombosis and you re-explore, the only treatment is reanastomosis. So after removal of the thrombus, you reanastomose, you just do not re-explore if the exploration was given in the question. If exploration was done in the question, then reanastomosis is the best answer here. Okay. And also according to the Graben-Smith as well, the best answer is reanastomosis. For ulnar nerve injury, 1 centimeter gap, what is the best line of treatment? I think this is the question. What was there? Primary repair is the answer according to our plastic surgery faculty as well. And from the Green's hand surgery up to 1 to 2 centimeter, you can go for primary repair. No, for 1 centimeter, you don't do a graft. So any, so can you just help me out with the options so that I can help you out with the answer? Now, this is the issue with the recall that many of the options are not given or it has been incorrectly recalled. So if the primary repair with approximation is there, okay, transposition with approximation, graft transfer, the best answer is either primary repair or transposition with approximation. Yeah. So basically, you do not need to do anything. You just need to approximate the two end. That is the answer. Okay. What was the fourth option? Graft transfer approximation. What was the fourth option? Nerve graft is not needed in 1 centimeter gap. Nerve transfer is not needed. Transposition with approximation seems the best answer as per your recall. Yeah. So coming to this question, that is regarding the Thompson procedure. I think this is taken from Bailey 27th edition. And what I felt is that there is some confusion regarding the option of whether buried subdermal flap was given or it was a dermal flap. Okay. Now, if you see paloidal sinus formation is a common complication. Okay. So if the option was subdermal flap, I think A would be the answer. And if it was a buried dermal flap, then the best answer would be D. But I would be happy if there was one answer, but if they have given both buried terminal flap and a palatal sinus as a common complication, then both can be the answer. And if there was a subdermal flap given in the option, then A is the answer. Okay, reconfirm also for that. Now, moving on to the next question, that is regarding the palatoplasty with levator sling, but no elevation of mucoperiosteal flap. I think this was the question. Any other addition in the question stem? I think one of the option was Wardle, von Langenbach, and Furlow. Yeah. So no elevation of mucoperiosteal flap is only done in Burlow. Okay. In all of three, this is again reference taken from the Graben Smith. So these are all for the hard palate closure, and they have a elevation of mucoperiosteal flap. So the best answer here is Furlow. Okay. Moving on to next, that is post-seroma with localized fluid collection extending into all proximal corners. So usually this is, I could not find a reference specific to MRM, but from this aspirant that is regarding the, were there any imaging finding given or only the clinical scenario was given? Okay. So there was a clinical scenario with fluctuation given on post-op day 5 and best management is asked. I think that is the question. Yeah. So now as if you go through the perioperative chapter of complications, and what they mentioned, if you read properly, is that if clinical suspicion is there, you can diagnose it as a seroma. But here, what I feel is that if USG was the option, next line of management would be a USG to localize and grade the seroma. That is what would be the next line of management. So here, not aspiration, but according to me, USG should be the answer here. Now, see, in such question, there can be, see, if next line of management is asked, USG would be the best answer. So I think again, there's a recall bias between best management and next line of management. Yeah. So according to me, the best would be USG. I would not answer it as aspiration in such where only a clinical examination is given. So there will be certain disagreement regarding you may go for direct aspiration, but just think about what you'll do in clinical practice when you have a patient with fluctuation with localized fluid collection. You'll go for next USG, you will confirm, and then you'll go for a aspiration, because even you will not go blind aspiration, you'll go USG guided aspiration. So yeah, even if it is fluctuation is given or not, but I would say it most probably as ultrasound and not aspiration. Okay. Next, I think there's a very straightforward direct image from Bailey thoracic chapter. I think thoracic surgery questions are directly taken from Bailey. See, fluctuation, if there is no redness, nothing is given, only fluctuation is given, that means there is a collection, fluid collection there. But always you go for radiological confirmation and then only you plan for further management. Okay. So according to me, the best answer would be ultrasound. So I think there's a very straightforward question regarding the NUS procedure, pectus excavatum. So I don't think there is much discussion here. What is true for Zaskar's disease? So it is, again, I think these are the options. Can you just confirm the options for this? The answer here is recurrent retroareolar disease or recurrent periductal mastitis leading to recurrent retroareolar infections. So, okay. So if such options are there, I think a very straightforward question. It is a recurrent retroareolar infection, and the other options are acute mastitis, fibroadenosis, thrombophlebitis. Okay, acute or alveolar mastitis, I think. Okay. Yeah. So renal biopsy is indicated in which of the following renal masses? Usually simple renal cyst, you don't do biopsy. Oncocytoma is diagnosed on radiology and post partial nephrectomy specimen. Usually another was RCC. Yeah, for that also usually you do not do biopsy, you go for resection depending on the clinical and radiological finding. So the best answer would be metastasis. Now, yeah, so I think this is also very straightforward. Answer is metastasis, in which biopsy is indicated. Epstein anomaly affects which cardiac structure? I think again, there's a very straightforward question taken from Schwartz cardiac surgery. That is, it is affecting the right or the tricuspid valve. Okay. For the renal biopsy, is there any discrepancy in the option and the question? So Epstein anomaly, again, straightforward. It is affecting the tricuspid valve. Again, I think there's a very straightforward, no confusion in this. Moving on to next, Gustello-Anderson, which grade is associated with arterial injury requiring repair? Again, I think there's a very straightforward question. That is, any fracture is vascular injury requiring repair is grade 3C. I think this is also very straightforward, no confusion in this. So that is it for this. I think I discussed around 20-25 questions. Now, very honestly, I feel that Neuro and Euro have been taken outside of the three books. So that is something which is tough for me to find the references. That is why it is taking some time. So I think roughly I have taken approximately 90 to 100 questions. Remaining 50 I'll try to cover tonight. Otherwise, I'll be covering it one or two days.